vissuto e che si spera ci siamo lasciati
after those people, but they should avoid coming to the hospital during that time. So we had to manage patients remotely. Because of that, in 2021, we had telemedicine that was provided to over 4,000 people. And we had to work in a safe environment. The healthcare company needs IT technicians and administrative personnel, and also personnel that looks after the management of sensitive data, because that is what a healthcare company should do, supporting healthcare professionals that have to work in the field. At times, healthcare professionals are required to do things in a manner that is not appropriate, and but they have to do what is appropriate. We are a small company, a small healthcare facility that looks after 26% of old patients on the mountains. We are in the Piemonte region. You can hear it from my accent, and we're border with Switzerland and Lombardy region, so we have troubles related to logistics because it is a mountainous area. So we must carry out these kind of activities, bearing in mind also we always have to guarantee a good patient-doctor relationship. People have to meet at the hospital, at home, and so these two figures have to meet up. And then the televisits and telemedicines are provided later on after a meeting in person. So this is the context in which we work. Then there is a special thing that I might tell you about. We moved from written procedures for some services, and the procedures now are structured differently. And also, for example, there were working groups that had the written procedures, and especially in the field of dialysis, and our coordinator decided to change the procedure, and she decided to introduce a video procedure. So first we had written documents, and then we made videos, a tutorial that was offered to patients that are our dialysis patients. And so today we have all those patients that are looked after from their houses. We used a matrix. There was a video procedure that was based on an IT system. And so those patients could download the video procedure through a code, and they could follow the process. Also, those who look after those patients are foreigners that are the caregivers that do not know Italian very well often. And so for them, the video was much better. Which was much easier to understand. Then we moved to video dialysis. We have a totem that allows to follow certain steps remotely, and doctors and other professionals can assess the a treatment and can check the treatment. So those patients that are particularly fragile are checked remotely through a televisit, a telecheckup, and then all things are assessed. So there is a telecheckup then. Then they make a report that and a file, a record, that are made available also electronically. I think that we are in a good place now. Thank you very much for your precious contribution and for showing us the concrete implementation of telemedicine and remote care. And thank you for remembering to us what we experienced during COVID times, because it is something that is unforgettable, and we must not forget it. We must remember that. We must draw lessons and improve things also based on that kind of expertise. I will now give the floor to Mrs. Masretti. She will speak about the costs and new models in terms of organization and technology. You have the floor. Thank you very much for this opportunity to be here with you. I am Mirella Masretti. I do scientific research and also industrial research, and the director of research and development of Medical Tech Strategies. That is a company that operates in telemedicine, in the telemedicine field. I would like to say something related to what has already been said by the doctor. That is the PNRR, the Recovery and Resilience Plan. It has a part devoted to medicine and healthcare, and also it takes into account various novelties at a national and European level. So the paradigm is changing. I'm talking about the paradigm of medicine, that is medicine for the population, initiative medicine, and also tailored medicine. I will now ask to show one of my slides. So when we talk about tailored medicine, we stress, we focus to the patient. We focus on the patient and not on the disease. So the patient is put at the center, and while in the past we used to put the disease at the center, so we have to take into account the patient's genetic characteristics, his lifestyle, and also the environment in which he lives. Then, in order to better plan the resources to use, we have to establish the health care needs of that patient. And then, thanks to the technological solutions such as telemonitoring, teleassistance, and so on, we can gather data. So a multidisciplinary team can be physically in the same place and gather data. So those data, the big data, are fundamental. There is a connection problem, so I cannot translate the speaker now. So, then, in the PNRR, the different levels and needs of the population is essential, because that allows us to plan and to plan the local structures. Then there's a series of models that are enablers for the construction of the local healthcare system. Here you can see 4 models whose fundamental element is technology, both in terms of organization, because clearly that has to have an impact on organization through technological support, but we have to manage the daily tasks. So we have to define the fees for those new services, and also we have to manage all the risks related also to privacy. Then there is the model that we use to gather data. There are new models of procurement also that are mentioned in PNRR, and also it is recommended to build private-public partnerships. But we have to include also the third sector. Then there is the issue of centralization of purchases. Then there is telemedicine in terms of monitoring, assistance, and care. And from a technological point of view, the fundamental element that is related to the issue of data is the possibility to have everything that is gathered in a manner that is interoperable through standard protocols that are HS7 or FIRE and so on, that allow to gather data, to link them, and also to define the risk for each person and his or her healthcare need. Can we move to the following slide? So the most innovative aspects of the documents that have been drawn up based on the recommendations of the PNRR concern, first of all, the assistance, the healthcare model that introduces population medicine and the model of layers and identification of healthcare needs. So we classify the population and different categories of risk. So we identify action strategies that align with the real need of healthcare and the consumption of necessary resources that is required to plan the healthcare needs. Then there is a logistical model. How is it structured? How do we structure the new medicine through it? I try to show it in a graph. And I wanted to show you the new structure of this model that was also described by Janice. There is a so-called healthcare district. There will be various healthcare districts, and each one of them will correspond to a population of 100,000 people. There will be community hospitals that will have 20 beds every 100,000 citizens, and then there will be community houses and hubs for general medicine and social assistance, and then there is the assistance at home with the management of the patients at home, and then there will be the hospices. Then there will be an operational center that is local, and that will link all those operators from all those entities, and it will allow to develop multi-professional teams, and it will also enable a link with 116, 117, that is the European number for non-urgent care. So, with this kind of models and structures, we will also look after patients based on his or her real needs. Then there is another important element that we'll look at when we plan this new model. It's important to co-design not only with the stakeholders but also with the users. So relationship between stakeholders and the patient and the healthcare professionals are key here. Everybody has to be engaged. Let us move to the following slide. So here you can see the local operational center. That is a very important element that looks after the coordination and the care for the person, and also it generates a link between the services and the professionals involved. It is a service that is provided every day of the week, and it has a coordinator, 5 nurses, and 2 teams of supporting personnel. That gives you an idea of the cost of this center. The goal is that of tracking and monitoring transitions from one healthcare center to another, or from one healthcare level to another. The monitoring of patients that are treated from their houses. is also monitored. We now move to the next slide. Let us now look at the cost models. What are the problems here? Basically, historically in healthcare, planning of expenses is always based on historic data. The healthcare vision has always focused on hospitals as a natural headquarters of healthcare services. The healthcare has always been based on hospitals, but this actually has its own limits. First of all, the historic costs are related to cost models that are different in the different regions, and so they cannot be applied to the various local situations. So these do not adapt to the real requirements of PNRR. So we cannot use the historic costs for local assistance because the reality is different, and that might lead to wrong assessments. So we need to define standards and services that are related to the real needs. We should define cost models that are related to direct costs. Whatever the historic and local context is, then we should adopt a cost model that is the same for the whole territory in order to monitor the various services at a national level. And then we should define accreditation criteria. And we should also monitor performances. So I hope I have provided a general picture, even though I had to present everything quite fast. Thank you very much for your very detailed presentation and for stressing the need for a tailored medicine that really meets the needs of each patient, that puts the person at the center. I will now give the floor to Mr. Giansaverio Fiolo, who is going to look after the communication between doctors and patients and the importance of communication in the doctor-patient relationship. Good morning. I am Mr. Giansaverio Friolo, and thank you very much for inviting me. I work for Sham, Mutua Assicuratrice, that is specialized in healthcare disputes. Please, I would like to share my slides with you. I was asked to speak about the communication between the doctor and the patient, which is a very interesting aspect because actually communication is at the base of any good organized service. So I will start with patients' expectations and also fears, which are fundamental for any person that has to be treated. So we should put at the center the doubts and the problems and the fears of each single patient. How do we achieve this kind of relationship? This relationship between the doctor and the patient is fundamental. It should not simply be mere analysis of clinical data concerning the patient, but we have to go beyond that. There is an aspect that is quite trendy nowadays, that is providing information on lifestyle and useful services. Such information are fundamental, but we also need to go beyond that. What does it mean? It means that we need to interpret communication as a real time devoted to care, during which the doctor also speaks to the patient in a humane way, and also the emotional aspects are considered as something important. So the doctor has to really understand the lifestyle of the patient and understand the patient. So the communication should go beyond clinical aspects. And so the relationship is a time for care. And then the various clinical activities and diagnoses and interpretation are provided. But how do we achieve that? There are some professionals that have this kind of gift for communication. Others need to be trained. So that is why we need to train healthcare professionals so that they can become experts at communication. And then there is telemedicine. So we should provide tools that facilitate interaction with the patients, also remotely. Then there are some issues related to it. Sadly, healthcare professionals have had to face COVID-19 pandemics. Not only it has shown the differences in the healthcare services in Italy, which actually have increased due to the different impact of the pandemic in different groups of population. In our developed country, we found out something that was not really evident. We think that normally a person is healthy because we are in a developed country, but actually, Europe, WHO has identified 5 factors that contribute to inequalities in healthcare. First of all, the quality of healthcare, that is, quality healthcare, and that looks after all aspects, care, and also how to provide care. Through some tools such as telemedicine, that is very important for chronic patients. So surely we need to have a tool that goes beyond the current problems, that is a lack of healthcare professionals, difficulty to reach the facilities. So we need something that can be easily used and that is sustainable for the organizations and for the users. Then there are the other elements that also generate inequalities, such as financial uncertainties, low quality houses, unemployment, and bad working conditions. Sadly, this is all very serious now. So what is our goal? Ensuring a healthy life. So we need to understand health inequality. And also, as it's been said by my colleagues also, we need to use telemedicine more, and also we should use new communication methods so that the approach is more engaging and more useful for the operator and for the professional and for the patient. Thank you very much for your attention. Thank you, Mr. Fialo, for having stressed the importance of communication and the relationship between the doctor and the patient. Based on my professional experience, since I am a lawyer and I am expert of healthcare, very often the profound need for healthcare disputes, there is a bad relationship and bad communication between the doctor and the patient. That is something that is often neglected, but we have to work on that. We have to be trained, and we have to train healthcare professionals too. So with this last speech, we conclude our first talk. I don't know if the audience would like to ask any questions. If there are no questions, I invite here Mr. Giuseppe Recchia. Please come to the podium, to the stage. He will be the moderator of the second talk, Future on Technology, New Devices and Healthcare Services. Mr. Recchia is the co-founder of Digital Medicine. Thank you. I would like to thank you. I am Giuseppe Recchia and I am a doctor. I have been working in the drug sector for a long time, but 3 years ago I changed job and now I work in the digital world. I co-founded the first of 3 startups, Da Vinci, Digitherapeutics. 2019 was the year before COVID, so we had a vision. And then last year I founded 2 startups, one for digital medicine and one for digital rehabilitation, so recovery. I invite here to the stage Mr. Elliot Schuba, CEO of At Intermedia, and Mr. Luca Borro, that is a bioengineer of the Pediatric Hospital Bambin Gesù. And also, we have Mr. Luca Foresti, the CEO of Sant'Agostino Medical Center, and he's with us remotely. This session is devoted to technology. The 2 words of the whole conference are science, future, and health. We will talk about health and future, and not just science. We will talk about technology, because science is the process that produces knowledge. And so typically that is studied at the university, and there are university researchers that dig deeper into the processes. Then technology applies knowledge to solve problems. And so typically this often happens in the universities, but also in the companies. And now it also happens in the startups that are centers that transform, that turn knowledge into applications. Technology applies knowledge to solve problems, and the problems that we're about to talk about are problems related to health. There are roughly 10,000 diseases on our planet, and the adequate therapies concern only 500 diseases. So many people have the other 9,500 diseases without a solution and are waiting for these solutions. So the technology looks for solutions. If we look at what happened recently, COVID. But we talk about COVID very often as if it was something of the past, but actually the COVID is very much present. The pandemic has not ended and it has not become an epidemic. So I think we should still wear masks, of course, but COVID now is less risky, less dangerous, thanks to the vaccines. The COVID vaccine is an example of how technology can change the history of the disease. Today we have new technologies and we have nose filters that allow to block the entry into our nose of particles up until 0,300 nanometers, micrometers. Then we have technology for rare diseases. We have genetic editing, that is the ability to modify the cells and to use the new types of cells for cell therapies, and that is a good example of that. Then we have a huge problem, the huge healthcare emergency that are chronic diseases. We have forgotten them because COVID has overshadowed them, but they concern 3/4 of our healthcare budget and of our population. So we need new technologies. Traditionally, technologies that we talk about in healthcare are called devices, as you can see here. And traditionally, the technology devices are machines, equipment. So for some years, we've had new devices that are softwares that are not physical, but the software as a medical device, in my view, is the great new area of technology. And indeed, we have entered in the digital transformation of health. Well, you know what it means. If you look back at 20 years ago, and it was impossible back then to travel or make payments as we do it today. So the digital transformation has changed our daily lives. Health has been reluctant to change for a long time. I'm talking about the health and the healthcare. But then with COVID, these two areas have had to start this transformation, which is something that we start to perceive with digital therapies that I'm going to talk about, and AI, robotics, and exoskeleton, and bioprinting to have new cells, and virtual reality. All these are technologies that shortly will be introduced into care processes. So I need to explain something here. The future is mentioned here and in the general title. The future is not distributed in the same manner in the different countries. In other terms, many of the things that we're saying today are the future. But for a Finnish person, this is not the future, because the future, our future, is different from the future of Northern Europe or of other countries. That is partly due to the fact that we, as a people, I mean the Italians, we are a digitally immature country. The European Commission carries out analysis each year in order to measure the digital skills of the population, and we are constantly at the bottom of the ranking. So clearly, for us, digital therapy is the future, while for many American citizens, it is something that has been there for 5 years. So I will conclude my introduction, and I will tell you that in the next 20 minutes, we will look at some of the different digital technologies that at an experimental level or at a practical level are changing our diagnosis and therapy pathways, the pathways through which we provide healthcare assistance. So we will look after technology and products, and the first speaker will be me. So we now change my role. I was the moderator, now I am the speaker, and I will speak about digital therapies.
Allora, le terapie digitali.
Digital therapies are an emerging topic of medical treatments. They're not very popular in Italy yet, so I'll make a short introduction about them. Well, we have hundreds of thousands of implications of digital products. Free downloads from digital markets account for over 400,000 applications that could be used for free. Digital healthcare or digital health services are applications that could be used to treat patients. So we have hundreds of thousands of applications that could be tailored on the basis of the user. We have different categories. The category of the industrial software that is used by healthcare companies, the healthcare services. The software in this case is a software that provides for administrative procedures, and it is the health system that decides to buy it. We have 100 applications for well-beings. They are used by citizens who are perfectly aware and who want to improve their situation. We also have softwares that increase the health of the sick, and that requires for more research in order for it to be used. This type of service is called digital medicine. Medicine because the objective is that of improving health, and digital because this is performed throughout software. The medium for this service is the doctor. The doctor um, has a series of data that allows him to improve the software. The software helps, but it's the doctor who provides. The software remembers patients to take their medicines and remembers them of possible side effects. We also have softwares improving the general health of patients. All these services have the aim of improving the patient's health, and in most cases, these softwares modify the patient's behavior. 40% of the health of a person comes from their behavior. If their behaviors are dysfunctional, they're likely to get sick. While um, if they carry out healthy behaviors, they're not likely
sanitarie.
they're not likely to get sick. When it comes to digital therapies, the difference with drugs is that the active principle is an algorithm and it's not a chemical or biological molecule. There are 3 different development therapies, and in the world there are 20. And most likely they'll become the first choice for doctors. So when prescribing a therapy, we have one for arterial pressure that's going to be presented here, one for the motion therapy, and one for the chronic dystonia. So no, I'm only talking about softwares that are on the market. In other countries, we have softwares for insomnia, ADA, and other diseases. How does the software interact with human beings? First of all, throughout an application or throughout a video game. It's a kind of a video game for motion rehabilitation that is based on a video game that has a patient carrying out some movements that may seem like playing, but they are that are actual therapies. There's one key point, and it is research. A new drug should be tested with clinical tests, but it's not really like that because you can actually test a product you can test a product digitally. Softwares are to be considered as toys because similarly to toys, they're extremely useful, but they can become harmful. That's why research and clinical trials are the pillar for the development of digital therapies. And not only once we have developed digital therapies, we have to look after all authorizations and the refunds. In Italy, our healthcare is universal, and services that are not refunded by the National Health Service are considered as non-fundamental. So there's a long process to embark on in order for you to obtain refunds. If you are not included within therapeutic pathways, it is quite difficult for patients to get benefits out of it. And then we have the patient. The work of the patient is fundamental. Usually, the interaction of the patient is blue pill in the morning, yellow pillow at night. Well, here, the patient must know the device. The application is on their phones, and therefore, they must take part into research and development as a member of the research team, and at the same time, they must be aware of what they are doing. It is a very long process that we have embarked on in Italy as well, and we really hope that over the next 2 years, it will bring excellent results and a few products. It's now time to leave the floor to Ottorello Rasciuba, CEO of Apti Medica from Rome. He's going to talk about new devices.
Grazie. Come aveva anticipato, noi vediamo tantissime tecnologie nel resto del mondo, noi siamo specializzati su Israele da 20
We are
anni,
specialized on
vediamo il
Israel.
nome la Startup Nation e questo
Israel
significa
is
che
called also
abbiamo
the
tutte
startup
le
nation.
tecnologie
So,
più
for several years, we've seen the
avanzate
most innovative
per la ricerca, per
products there.
l'applicazione dei
And
sistemi
Italy is
che
actually
possono
one of the main
ospitare
countries
questi
for the testing of these products.
Mick Hofer, inventore di un
Mick
esoscheletro
Hofer was the inventor of an important mesoskeleton. He said that we use technology, we're not inventing anything. Hence, digital technological innovation, the innovation of devices of image analysis, will allow us to understand how we can better help doctors doing their job. Technology exists. How can we apply it to the patients?
non di facile, assolutamente, noi li chiamiamo wearable, no? Perché si
We
lavora sul
call
concetto
this,
come
I
sarebbe
mean,
arrivare a un dispositivo medico che può essere applicato come e come può aiutare il medico non è
wearable
facile.
devices are the future.
Che cosa succederà? Noi facciamo un
What
esempio,
will happen?
in Italia c'è un progetto sui
In Italy, there's a
droni
project
usati
about drones for the transportation of
facciamo
blood and organs. It is a project that started in the Veneto region, and there's one main request. When is it that urgent?
Ciò è che ovviamente la logistica per lo spazio
Let's
aereo
leave
è
aside the logistic and the aerospace.
a 300 all'ora da un tempo a un
Let's
altro.
just focus on the fact that there are drones that can transport from one roof to another at 300 kilometers per hour blood or organs. The question is, when will we be able to use it? As for all other wearable devices, it is quite clear that the exoskeleton was a great revolution for
Diamo autonomia
tetraplegia
alle
because we are giving an alternative to people
persone
living on a wheelchair. This is something we found out thanks to research and that allow people
ha dato una serie di benefici
to
al paziente
get back to walk up the stairs, walking. We're talking about people with cardiovascular problems, and thanks to this system, the exoskeleton was made available to patients. There are also other technologies, and people who got heart surgery
derivazioni dove il cardiologo sa esattamente che cosa succede al paziente, l'intelligenza
will
artificiale
be
analizza
analyzed
cosa succede
by
al paziente
artificial intelligence that sends alerts. In order to get to this point, we've needed countless time for validation and research.
del mondo sanitario in tre grandi blocchi.
I'll divide the future of the healthcare system into three parts. The part of artificial intelligence and big data, the second part made of by hardware technology and healthcare devices, and the old world of logistics, which is extremely relevant.
In alcuni
The challenge in Italy is that when a child is born, for 50 years, artificial intelligence is analyzed and compared, and deductions are made. Of course, they should all be validated together. The shared digital clinical record is a key issue because we are a country that is not moving forward from the point of view of the digital world. It is like if you build the highways and you do not establish who's going to take control of that highway or control over that highway. If we are not able to protect our devices and our data, this is a problem to expand their diffusion. This is true in telemedicine, but also in other fields. We are embarking on new projects, and there are countries that are quite ahead when it comes to this topic. In Italy, we've never had these big problems with hacking. So it is true that we are a country that is still lagging behind when it comes to the digital, but I think that the cultural wall has been broken. We all have a smartphone, and our parents have them as well. So, and this is positive. In other parts of the world, other wearable devices are worn, such as one for people who fall down. They use a belt, and the belt helps them keep the balance.
La domanda è a chi lo diamo, quando lo diamo.
The question is always the same one. Who are we going it? Who are we going it? Who are we giving it with? When are we giving it to this person? Italy has designed several devices. The experience an Italian doctor has in public hospitals is quite rare all over the world. I would like to conclude with a project about radiotherapy we're carrying out in Italian public hospitals. And thanks to this technology, we can rebuild organs thanks to magnetic resonance. And so we simulate an installation of radiotherapy or brachytherapy that burn the tumor cells in a few days and breaking the DNA chain. Thank you once again for sticking to the time slot allocated. Startup Nation is in Israel. I work in the digital world, and it is impossible for you not to work with Israel because they are the best in the world. As I said, there are 3 digital healthcare processes we're researching on. However, the first digital therapy I hope will come to Italy. I hope will be an Israeli one. One of your technologies is already being used in France, and it will be used in France and Spain too. It allows you to increase by 40% the survival rate of patients with lung cancer, and they provides for, and this technology provides for an increase of 96 months in the life of a patient. He's also mentioned organs regeneration. This is one of the ambitions of medicine, and nowadays we see the possibility to do it for real. Dr. Luca Bollo, who works at the pediatric hospital Bambin Gesù, deals with bioprint, so he prints these 3D technologies with 3D technology. And let's now focus on the viability of this process. Well, thank you very much, and thanks for your introduction. I'm going to talk about 3D bioprinting. This is a very interesting technology in the clinical field and in the research field. In this slide, you can see a salamander that can regenerate their tissues without help. This slide is the symbol of what we would like to happen to human beings, that is to say, the need to regenerate tissues that have been damaged by age or by other factors, like oncological and neurodegenerative diseases. So we're interested in all these diseases, and we are interested in finding a solution that passes through research and new technologies. All these pathologies provide for one damage, which is the life of an organ that has an effect on the life of the patient, and that's why we thought about 3D organ regeneration. This is useful both for in vitro observation, but also with the aim of developing new drugs and new devices, passing by bioprinting. Bioprinting is the use of printers with biologically active products. So we put biopolymers or other materials in order to go for 3D printings. In our body, there are 13 billion cells that are organized in a very complex area. In this slide, you can see the organization of cells. It is a very complex one. So within this cellular architectures, we'll be able to see these features. So when doctors study to find a treatment to a disease, they observe and cultivate cells on a 2D structure. 3D forces us to create structures that create geometries in the space. So we can take cells, we can print them on scaffoldings with the geometry we prefer the most. Here I have simplified the limb of the salamander in order to find an organ in space. This is ambition, this is not reality. This process is made possible throughout the use of 3D printers. The 3D printers are made of extruders that contain viscose material that is put inside a syringe and that can destroy the material inside a plate. This is called the Verrini or Petri dish. The objectives of bioprinting are the following one. Well, first of all, regenerating human tissues that have been damaged by certain processes, reproducing, bringing back in vitro the functioning of a single organ. In fact, we could take oncological cells, rebuilding in vitro their tumor and making screens in order to see the action of drugs on that patient. So we can study drug screening phenomena in order to understand the reaction of that disease, of that system to that disease. And I'm going to provide you two examples of what we do at the hospital. In hospital, the first one includes patients suffering from tracheobronchomalacia that provides for the size of airways due to a damage of tissues. Up until now, patients with these problems have been treated with a metal alloy stent that is placed on the site of the defect via endoscopia. These tools keep airways open, but the problem is that they do not get reabsorbed and they do not grow with the child, so they stay there even if the child is growing, and this can provoke problems when the child grows, and quite often it is asked to remove them. In the US, our hospital had the possibility to implant a bronchial splint that, as you can see in this image, is a kind of sleeve that is applied outside the damaged airway, and it enlarges it as if it was a spring. We have printed it in 3D with the basis of three polymers. What we have obtained is here in my hands, and it is the small device that carries out important tasks. This device has holes because it simplifies the sewing procedure. On my left, you'll see the initial condition with the shrunk lung and the post-operatory phase when the size of the lung is restored. The tracheal tissue stays soft. My last example is a research example. Is the 3D printing of scaffolding that must have the aim of regenerating bones. Bioprinting is a key thing, and we are studying this project, and we have printed 3D a scaffold, and we placed stem cells that can eat every type of cell, especially osteoblasts, creating a bone. And we've seen that after having cultivating them, they were feeling good on the scaffolding. The biopolymer wasn't hitting people, and they were stimulating particles for the production of bone. So this way we could stimulate the creation of bone and the creation of ALP, an enzyme that is included within osteogenesis. We're quite happy about it because we are continuing work in this direction. The take-home messages are the following. Bioprinting in 10 or 15 years may become a solution to organ transplants, and it is also an interesting technology, and surely research centers should be held by governments in order to delve into and deepen this technology. Well, thank you very much. Thanks for answering our questions, and thanks for showing once again the commitment of Hospital Bambin Gesù. The last intervention is slightly different, because we have presented technologies from the point of view of research, of producers and provider of energy. Dr. Luca Foresti, administrator of St. Augustine's Health Center, presents it from a slightly different perspective as a user of technology. What kind of technology does the healthcare really need? This is one of the questions we have posed him. Mr. Foresti, you have the floor. Well, thank you very much. First of all, I'd like to show you a different perspective than the one you have mentioned now. The problem I'm going to tell you about will lead us to think whether we'll have what we really need in the next 10 years. Two significant facts are happening. First one is aging population. The aging population produces the increase of healthcare service, of the use of healthcare service. There's one thing that is happening in Italy, and it is the decrease of people working in the health sector. Hence, in the next 15 years, there's going to be shortage of doctors, nurses, and other medical professions. These two elements combined together provide the perfect storm, because if we do not use technologies that are the technologies with the aim of streamlining the contact between the patient and the doctor, so if we do not tailor our offer, we won't be able to manage all needs.
Darvi i numeri di quanto grave è questa situazione, credete.
I won't be able to tell you the figures of this situation, but what was going to happen over the next 10 years is going to be dramatic. In order to be more complete, what kind of technology do we need? Well, I'm going to provide you with a few examples. Let's just think about our GDP. Chat is going to be of the essence for GDPs in the future. We can say that except a few doctors who use WhatsApp in an illegal way, there is no technological structure that allow GDP to use chats. A Finnish subject using this technology says that 80% of interactions between doctors and patients can be managed by the chat, while there's a residual 15% that require of an in-person visit, an in-person check. We have to work this way in order to streamline the scenario, so that because in the next years the number of GDP is going to drop by a half. There's a second example I would like to make. It is about radiology. This is an example of technology existing already. They allow for the loading of this information on clouds, and they can be downloaded from wherever in the world. So I'm wondering why is this a technology so important? It is because you have doctors that specialize themselves. So you have the breast radiologists, the orthopedic radiologists. Therefore, this specialization provides for two effects. So the first is that the speed with which these doctors can see the images and do the diagnosis is very high. And the second is that the quality of the person who does the diagnosis is higher, so there are no false positive. And this is an example of technology going the right direction. But what do we need? We need a technological topic, and we must allow ourselves to have also radiology technicians in order for them to focus on that piece of process which they're competent about. This is not yet possible in Italy because regulations provide for the physical presence of radiologists. So most radiologists are present in situ, and they make records about everything, lowering efficiency. There are other examples I'd like to make that are related to the wearable devices. Nowadays we have cheap wearable devices are not, and these data are not used by doctors but by the patient. Well, nowadays we are before a situation in which in order to do the anamnesis or the diagnosis, and in order to monitor the behavior of the patient once the therapy has been established. So the exchange of these data with the doctor is fundamental. So this is another example.
Then there is another example that was used by LATE, that is an Israeli organization, is giving to families at home tools that allow to take snapshots in the throat, in the ear, in the nose, and transfer those photographs to the GP. In this case too, we can do something that would require an appointment, a physical checkup, and that is another advantage for the doctor. Finally, clearly, the mother of all battles is something that we called electronic health record 2.0. That is the idea of having all data related to a patient, whatever, whoever was the doctor, in one single tool that can be used by all the doctors, who then will check the patient. What is key here is the fact that we can apply algorithms to those data, algorithms that must be specialized for the doctor that looks at those data. So the different specializations will have different algorithms that allows the doctor to have alert without reading all the different paper records of a patient. So once again, we can save time, we can save the doctor's time, and also increase quality as a consequence, even though we have less doctors than required. So to conclude, we are facing a revolution in which we cannot have a healthcare system that is centered on the doctor, where the doctor does everything and the other professionals, healthcare professionals, are treated as assistants of the doctor, but we instead need working teams where surely we have the doctor at the top that is responsible and has to manage all the processes, but below him or her there are professionals that are empowered and can do much more than what they are allowed to do in the current system. So to conclude, we need technologies that allow to face a decline in the relationship between the doctors and the patients, and talking about not the relationship but the ratio, which is something that is increasing and will increase dramatically in the next years. Thank you, Mr. Foresti. We have reached the end of this session. If there are no questions by the audience, I will sum everything up into words. We need to change. That is what all our speakers wanted to say. We need to change technology, healthcare technologies. We have very well-known technologies that COVID forced us to use. Then we have new technologies that need to be developed, as we've seen. Developing technologies require the support of civil society. We need a pressure from the civil society in order to develop such technologies. We shouldn't simply aim for efficiency, but also for effectiveness in order to do something that we cannot do now. So not only we have to do things better and at a lower cost, but we have to do something that we cannot do now. But anyhow, technology is an enabler. It is not something that transforms. We have to do the transformation. We are a people and a country that is at the bottom of the ranking in a digital literacy and a health literacy. So that is why we have trouble changing things rapidly. So training and information are priorities in which we need to invest. So I think that today's meeting constitutes an important element in order to favor this greater awareness and in order to train a country that really needs to change, as we've said during this session. So thank you very much. I would like to thank the speakers, Mr. Teshuba Baron Foresti. I will now invite Mr. Corrado de Rossi Re, that will be the next moderator. Thank you very much. I would like to thank you guests and also the guests that will soon come here. We have now reached the core of our journey into the future, technological, scientific world of medicine, but also of healthcare, because we must not forget that any medical, scientific knowledge at one point needs to be implemented, and implementing a scientific discovery or a new technological discovery not only requires regulations, but also it requires organization, and that is the healthcare that surrounds us. And we are lucky in our country because we have a national healthcare service that puts the various knowledge applications and implementations at the service of everybody. The title of our third session is Visions, Strategies and Goals. How does medical science evolve? Because we talked about strategy and we talked about a fascinating future, but this future involves also clearly the citizens and clearly the production systems, but surely also the professionals that then are responsible and need to apply to their patients what is provided by technology in order to reach the future. So what is the fil rouge that links all these reflections on the future and the hopes regarding the future? We will try to find that out with our guests. So 2 people are here in person, 2 other people are attending remotely. So first of all, I would like to invite Ms. Chiara Paglino, Head of Medical Affairs, and then Ms. Cinzia Marano, Italian Medicine Director of Moderna. And thank you very much for being here with us. And then we have Mr. Luigi Cavanna, that is the President of GIPON, that is the Consortium of Oncology doctors in our country. He's the Director of Oncology and Hematology Department of Piacenza ASL, Dr. Giorgio Moretti. Mr. Giorgio Moretti, who is also attending remotely. He's the President of Daedalus, who will speak about the manner in which we can link all those aspects together, and I will talk about technology applications. First of all, I will give the floor to Miss Paglino. She's going to speak about One Health. It seems like a paradox because we're talking about futuristic sci-fi technologies, and then we need to take a conceptual step back, because actually these technologies are not per se technology, but these are not technologies for the sake of technologies, because we understand that we are all linked to one fate, and so we have to take action based on that concept, on that awareness. Can you hear me well? Yes. It seemed switched off. I am Chiara Paglino. I come from the medical management of a multinational company, Beringeringheim, that operates in human and animal health. And that is one of the reasons why One Health now represents us. It is a pleasure to be here with you. I've listened to many interesting speeches. It is a very wide concept, because the concept One Health actually was coined in 2004 during a congress that had as a title One World, One Health. But actually it is a very ancient concept that was known also in ancient Greece. It is a trivial concept from one point of view. It is very simple because according to it, on this planet, the health of the human beings and of every animal and of every natural element is indissolubly intertwined with every other element. So it is a very simple concept. I chose one definition among the many available definitions of this concept of One Health. One definition that, in my view, is related to one element that is fundamental, that is the concept of multidisciplinarity, of the need to mobilize in relation to One Health concept. I'm talking about mobilization of all sectors of the society and of government and politics. Many institutions have focused on One Health concept and thinking about the WHO, the FAO, the European Commission, and the Istituto Superiore della Sanità in Italy, EFSA, EMA. EFSA has had a meeting of 4 days on the One Health concept. This kind of interest is surely based on some issues that are quite specific, such as the healthcare of animals, the fight against zoonosis. That has been a topic on which we focused very much recently, and the health of the food chain, that is also very important as a concept. But in the last years, also due to the pandemics that has hit us so hard, and due to the speeding up of climate changes that we've all noticed very much, the concept of One Health has become a real paradigm to rethink the definition of health and well-being. Also, from a visual point of view, you can look at internet and you can find many different representations of One Health, but you can always see these three elements that are interconnected to one another and dependent from one another. Then there is another quotation from Miss Capua that I very much like, because it highlights one different aspect. We have always had an approach to animal and environmental health that was based on the purpose. So their health is important because it has an impact on human health, while Miss Capua teaches us that instead we should think that each element on our planet has its own dignity and the right to exist and to be healthy. So in this sense, it is based on the responsibilities of the various institutional and social profiles who need to rethink this notion of health. So in this sense, it is a new paradigm of One Health. There is an interesting approach that is more and more common, and it is a multidisciplinary approach, because if we need to rethink the notion of health and well-being, we have to do it in a very wide manner. We're not only talking about doctors, veterinaries, and not only biotechnicians, but also professionals of the social world, sociologists, theologists, and so on, professionals of healthcare policies. They all require a new model of collaboration among them. So that is why we need this multidisciplinary approach. In this way, the object of research is a part of the system, because the goals of research are co-designed by all the parties and by all the interlocutors, all the stakeholders, because at the end, the purpose changes. It becomes a social purpose and not only a specific purpose, but it is a general, wide social purpose. Why does a company focus on this aspect at one point? I mean, the aspect of One Health, because actually pharmaceutical companies have a huge responsibility. We as a company operate in a human and animal health, but we have to do it in a sustainable manner. We have to identify a direction for sustainable development that is in line with the environmental well-being in line with the One Health approach. I think it's been beautiful to see that this year the Health and Life Science Task Force focused on One Health concept, and it was one of the panel's recommendations, and so then it was presented at the G20. So One Health is the third recommendation, that is strengthening the healthcare system by promoting also a greater collaboration that is also wider, including the collaboration with the companies. Bearing was mentioned for 2 specific best practices. The companies were mentioned too in that document. And it is a pleasure for me to tell you this. So my company was mentioned regarding the prevention of diseases in Pakistan, and another project with vaccination campaigns that were adult campaigns in 17 different countries in the world. But the single initiatives actually are not enough, also from the point of view of the company, because single specific initiatives might get lost, while the One Health vision should be embraced, should become part of the company's commitment, and it should guide strategic choices in terms of research and development. Beringen has translated that through 3 pillars that are the 3 pillars of sustainable development for future generations, that are more health for humans and for animals, more protection for their communities. So we should start with our colleagues and move to wider projects such as making more health and then more green, with a quite big commitment here, because we need to reach zero carbon, zero emissions by 2030, and reduction of water consumption and use of renewable energy sources only. That is our commitment. And we have put it inside our strategic development approach. So one last slide where you can see a series of initiatives where there is one central coordinator, but then they are implemented in every country all over the world where we operate. It is a way to take steps forward. Each company can do it alone, but should also collaborate with the other companies in order to have sustainable policies, because actually nature takes actions and it has its own timing, and its timing do not wait for the human beings and their discussions. Thank you. You talked about climate. Climate remembers to us that nature takes action while human beings lose time reflecting and thinking. We have here Mr. Cavanna. Thank you for being here. For a few minutes, you are going to embark on this journey with us. We're not really talking about the future, because actually precision medicine and precision oncology in our country too is now a reality. It is a period, a time in which fear for too much technology might lead to care that does not put the patient at the center. Well, actually, technology puts the patient at the very center. Thank you very much. I would like to thank the doctor. Thank you for your very beautiful speech. It is a quite universal concept. I focus on the genes, but everything has to be part of a system. Today, tailored medicine that is more and more advanced allow us to find treatments that are very, very tailored based on the biological anomaly of a tumor, and so they are targeted and tailored. The term tailored is a bit wider because we should avoid something. I say this also to the young doctors. Today, we tend to look for the last receptor, the last sequence in which maybe a medicine was developed that can change the diagnosis of a patient, but actually a certain anomaly, a certain receptor is inside a cell, which is inside a body, that is a person with his or her life, his or her experience, and all that has to be considered very carefully. That does not simply mean that we have to be good, but there is a risk here. In the face of more sophisticated methods, and just think that in the recent past, identical cells in the microscope could lead to two different tumors. And so these are profoundly different. Also, they require very different therapies that might change the fate of and the prognosis of a patient. That is very important. But we also have to remember that the human being, the animals, and the whole world should respect each other, and that is a fundamental aspect. We need to remember that my life cannot be lived well if also the things that surround me live well. And also there is the issue of molecular biology that has to be applied to the person. Only in this way we can have tailored therapies. And then I would like to state one last thing, and then I will stop. Today we speak a lot about gene sequences and biomolecular therapies, but also we have to work in order to prevent time toxicity or travel burden. That is time the patients lose by traveling, by waiting at the hospitals. All these make our success vain. So the patient has to be treated in a holistic manner. Of course, we need to know our goal, but we have to improve as much as possible the quality of life of the patient. Thank you very much, Professor. I can sum up this by saying the right therapy to the right patient at the right time, at the right place. Thank you, Professor. Please stay with us because there might be questions from the audience. We talked about therapy, but we also have to look after the environment and ourselves through prevention. Thank you, Corrado. Good evening, everybody. I am Cinzia Marano, the head of medical direction for Moderna here. We are talking about innovation in prevention. In these last 2 years, we've heard speaking about the new vaccines, mRNA vaccines. Up until today, we've been used to traditional vaccines that are based on injections, on injecting killed viruses that then allow our body to respond to them when they are exposed to a specific infection. But the great novelty that we're talking about today, and that makes me really proud, thanks to my colleagues who are researchers and who have led us today to the situation that we are experiencing today, that is almost the end of the pandemic. Even though we have not really reached the end, we are going through a transition. But anyhow, the mRNA vaccine is basically based on ribonucleic acid messenger molecules that inform our immune system on how to create specific proteins to fight against a specific virus. So actually, it is a change of paradigm, so the old paradigm has been disrupted. So we do not inject a virus, we do not inject a bacteria in our body, we simply provide information that then allow our body to respond by creating the neutralizing antibodies that neutralize a certain virus. Obviously, this approach that that is very rapid, as we've seen, allows us to update the vaccine and create combinations of vaccines. The important aspect here is the speed. So once again, a totally different paradigm from what we've seen before. Clearly, we've had to face a pandemic, and so clearly we had to act very fast. And in order to be successful and then ensure vaccination campaign and develop those vaccines, of course. So if we take a step back, we move to December 2020, when we identified the sequence of the virus that was causing these types of pneumonia that were particularly worrying. From that moment up until the final sequence of the RNA the RNA sequence, only 2 days passed. Then we developed the vaccine, the final vaccine, in 11 months. So in 11 months, we developed a vaccine which was then used all over the world in a very capillary way. So speed was key, and that is why the development of vaccines has to be very flexible, especially mRNA vaccines are very flexible, so we use a mathematic computerized algorithm. Now, within a few months, we've been also able to update those vaccines based on the existing variants. Then there is also a great novelty in this technology that is linked to the production of such mRNA vaccines. Traditionally, we are used to large bioreactors where traditional vaccines are produced based on viruses or bacteria, but the mRNA technology allows instead to add the necessary equipment for a vaccine in a container. That means that this technology can be transported very rapidly to those countries where there are no production factories. As I said, actually, these are just information that are put inside our body. And so there is a great potential here, not only in terms of prevention, meaning that we can keep developing vaccines that are based on mRNA for the prevention of respiratory diseases or for diseases that can cause pathologies that are congenital pathologies, but also we might be able to treat rare diseases where technology can actually help to communicate to the body that can create a certain protein that is lacking and that causes a certain deficit. Lastly, we can use this technology as a therapeutic vaccine in oncology, clearly. So not only we have specific tailored therapies for specific patients, but also more in general, we can identify a certain protein that in order to attack a certain element and reduce pathologies. So in the future, we will keep focusing on those aspects, on the speed and on flexibility of this technology in order to use it more widely also for pathologies and infectious diseases that are not only here in our Western countries, but also all over the world. Thank you very much, Ms. Marano. I think that we now have the President of Daedalus, Mr. Moretti. I can see him now. Good evening, everybody. Thank you for being here. Medicine was already complicated, but now it is becoming very, very complicated. That is why you have these new kinds of programs today that have been also mentioned as one of the new novelties. Can you speak about them, Mr. President, and can you tell us why they are useful? Good afternoon, everybody. In the previous speeches, I have identified something that was recurring. The profession of doctors is now being supported for 50 or 60 years by new methods and new technologies, new drugs. So we are allowing the doctors to be supported by a huge amount of information that apparently are all fantastic, because clearly there has been an incredible evolution, but at the same time we are making things more complicated for doctors.
If we can remember the tools of the GDP, you surely remind about your childhood. That was like a starting point. And doctors specialized more and more. So we have unpacked, so to say, the activity of doctors over a week. Doctors do 52 different things when carrying out their job. They do it in different conditions, in different places. So what happened? Everything around doctors has changed and will keep changing. So in order to support them in such a complex context, we have to design new methods, because the support they can rely on is not adequate. We should acknowledge our mistakes. We have forced doctors to automatize the current clinical processes. So we can say that there hasn't been a real support to this storm of information. What has changed over the past few years? Well, first of all, technologies have changed. It would have been difficult to provide doctors with high-quality tools because the technology was not so supportive. We can say that over the 4 or 5 years, the world has radically changed. But that's not enough. there's a key topic we should analyze. This topic is an effective understanding among doctors, not inside the same unit, but within an expanded context. COVID sped up the diffusion of telemedicine. However, and moreover, if we make fully understandable and comparable, as well as processable, so to say, information among doctors, we are enabling doctors to do a revolution and to get hold of tools they could have never relied on. So we should advance technology and the capacity to collect data. We should make ourselves familiar with decoding systems and data collection systems. So the only information about the patient should be made understandable, labeled, and reusable. The fact that it could be reused allows for full cooperation among doctors, both within their unit and outside their unit. In their unit, they might use their own language. But today, thanks to machine learning and other elements, they can transform words or digital paper into clinical contents that are semantically equivalent. This is the basis if we want to make decision supporting tools available to doctors. We want to do so in order to speed up the secondary use of the data, hence clinical research. And secondly, in our will to process guidelines and best practices in a way that they could be exchanged and shared, and to have them applied in the daily routine when doctors are forced to manage different levels of complexity. When a doctor must take a difficult decision, the doctor has to process a huge amount of information, and these tools will support the doctor. They will never replace the doctor, but they will surely support the doctor and make their work more efficient. Well, thank you very much, President Moretti, for your speech. I'd like to underline the last two words, the last sentence you've said. These tools will support doctors and they will never replace them. However, it is true that the doctors are faced with a quantity of information that requires a certain type of support. Are there any questions from the room? Well, thank you very much to all our guests, Professor Guaglino, Professor Gavanna, Dr. Giorgio Moretti, President of Daedalus, for accompanying us in this fascinating and long journey in the most advanced applications of technology to remote medicine. Now I'm going to leave the floor to my colleague, Mr. Rossimori. I've known him for several years. He's one of the most knowledgeable people in Italy about digital healthcare. So you have the floor. Good evening, ladies and gentlemen. I'll try to be quick because I think we're almost at the end of the day. Thank you very much for staying until the last talk of this session. Citizen, patients, the future, and treatment. The digital world. First slide, please. I have prepared 4 slides with very big font. Health and social system needs for radical change. Law Decree 77 has just been passed. We've heard a lot about telemedicine. The question is, how are we going to change the system, and how can we make the most of the opportunities provided by new technologies? I have divided treatment processes and technologies into 3 sections. The first section is the type of transformation, scarce or null, that do not modify the daily management of processes. An example of it could be the current health record, which is a collection of PDF records that do not change the treatment model. It doesn't change the relationship between the patient and the doctor. It is only useful to transfer certain documents, such as prescriptions and results. However, it doesn't change the way a patient is treated. Second, localized transformation to make certain sub-processes effective. This is quite specific, but it does not change the healthcare treatments process. And here we have to distinguish between those who are responsible for technology and medicine, while the Ministry for Health and the Ministry for Innovation, together with the Ministry of Economy, with a little activity, created these tools. I mean, we can say we managed this transformation because the Ministry of Infrastructure looked into it. But when we observe the treatment processes, we need a strong intervention by the health sector. Third, deep transformations that provides for an integration that is addressed to a high number of subjects and with a strong use of technology. The main people, the people who are in charge for this transformation are managers as well as regions and competent offices. It cannot be the local healthcare system providing for this change. Small changes could be made at a local level, and that's fine. But if each local unity does a minor change, we are in a state of chaos because there are too many different processes. So as for scarce or null relations, the technology is fundamental. They are independent of the sector. Optic fiber is okay for everybody, as well as Wi-Fi local receptors. Interoperability standards of the internet are suitable for everybody, and they work quite well. A second level is healthcare-specific technology system. It involves the dematerialization of paper documents, which means that you transform a hard copy of a document into a PDF that cannot be processed. And this is our current health record that nobody uses. it is useful, those 4 things it can do, that is to say, to send results and transcriptions and prescriptions, but those records cannot be used because they have no title. I know it is a prescription, however, a person who's chronically sick will have 100 prescriptions. How can he find the one he needs? How is he going to index them? There's no way to do it because those documents are not structured. Apparently, the next health record will provide for structured documents, but it lacks the concepts of other levels that we're going to analyze now. Digitalization, administrative procedures, the appointments, reservation. These are things that can be done and that are not invasive from a technological point of view. Localized transformation. What are they? They are independent transformations. They are independent from the local context. This is what happened during the pandemic. There were doctors prescribing treatments over the phone. Doctors were speaking over the phone with their patients even before the COVID. When the patient had a problem, they would call the doctor and they would receive an answer. If such a phone call is made throughout a phone call, this is better, but it still has its limitations. There are things that could be seen at the same that could be seen the same way, both remotely and in presence. However, for some other things, the doctor really needs to see you in presence. The monitoring of patient with heart diseases involves the GDP, the heart clinical unit of the hospital. So a minimum of organization is required. And in fact, things were done even before the pandemic. In fact, there were 500 authorizations by local health services. So telemedicine was already popular before the COVID. And as I said, there were authorizations for telemedicine at the local level. So it is nothing new. However, telemedicine has been reinforced during the pandemic. Next slide, please. Deep transformations. Transforming the healthcare system in the current context of aging population, of the increase of chronic diseases, requires for more prevention, for more communication, for better lifestyles. These are elements that are included within the health plans, but they are not implemented. And I think that with technology, the implementation could be radically improved and streamlined so that they are applied all over Italy in the same way, not only in a few privileged areas. Chronic care model, when applied to different pathologies at the same time, becomes a different problem to be faced with. In fact, it is difficult to adopt a system that works quite well for a number of diseases, because you have to involve different doctors from different disciplines, and especially you have to take into account that you are not inside a hospital with a stable group of doctors, but you are based in an area where there are different professionals all the time, so you don't have a stable group. We only have the USC in Italy, or UCA, that provides for a kind of a stable local unit of doctors. All other groups are groups of professionals that have gathered around the patient, that specific nurse, that specific doctor, that specific specialist, that specific physiotherapist or caregiver. So it's not a team of professionals that work together on a daily basis. It is a group of people that gathers around the patient and it provides for several problems. The other challenge is that of combining so many different programs in order to draft a multi-annual regional program. I'm skipping my intervention about the health record because I think I've said enough. The current health record doesn't have a clinical aim. It is not used because it wasn't designed for clinical use, and I have never read the clinical specifications on how to use the health record well, because they've never been written. I was a member of a group about 15 years ago, of a group of the ministry that wrote that document, but that document was largely ignored. The document we wrote went towards the clinical use of the health record, and there was no debate about it. The Ministry of Health, together with the Department of Innovation and the regions, drafted the current health record that was born dead already. It was in a coma already when it was born. And that's the reason why it is used by everybody, because it is compulsory. Instead of opt-in, they did an opt-out. With an opt-in, you can choose. If you opt out, you have to say you don't need it. So everybody uses them, but there are no data inside. So before a health record, we need a healthcare app. Similarly to the app you have for schools or high schools or universities, you should have an app or a portal for you to carry out your job as doctors. If you're a student, you have an application or a portal that includes the exams you're given, the subjects you have to study, the timetables, and all the information you need in order to get your degree. And I think that the same thing is needed for citizens, so that only by using an application they'll find whatever they want. Digital therapies are going to be implemented, and I think that such therapy should be accessible throughout an application. And the data that people get from a digital therapy should be included within that app. An app that belongs to citizens. Some of this data will end up into health records and for the use of professionals. Most data are of the patient, and it is the patient who decides who they're going to show it with. If there's no way to collect data about citizens before treatment, afterward, there is no way to load the data effectively. In ITC, we usually say garbage in, garbage out. So it's the same thing with health records. There are no data, so it's like a garbage document. So GDP should send data to the health record and to the app of the patient. The ADI systems should send data to the public system. Private systems should send data to the public system, to this general system, that it is both for public and for private healthcare services. If I ask Google all the data they have, Google sends me all this data. It takes a while to send them because they are scattered all over the world. They are in terabyte. They know everything about me. Google knows everything about me, where I've been, what I've done. But if I ask Google for this data, they give it to me. If I ask my data to my healthcare unit, they have no idea where they could get them from. They could get some of them, but they have no idea about my real clinical data. So we should start from there. We should start from local healthcare units and from hospitals. They do have an official health record, however, with a legal value, but the rest has no legal value. So legally does not exist. I hope that 2.0 health record by Colau will have something more. I think it lacks off a couple of fundamental points. I wrote a letter about it, but I received no feedback about it. There are two key things that are missing, which are who has seen the patient and why. It is a simple notification, something that says, me, Maria Rossi, I have seen Dr. John Smith because of this and that. It may sound as a trivial message, but I could attach to this simple message all the clinical results and documents that are related to that first visit. And there's also another point that is missing, the point about the problems of the patient. So what the patient has said about his problems with diabetes or heart disease. And by doing so, I can combine data, I can process them, and I can reorganize them. Without this information, data scattered, and we cannot structure them. Of course, afterwards, we'll need codification, we'll need coding systems, but this must be a start. However, I haven't seen an official document saying that we can adopt codifying systems. Well, I've left the panelist of this session sitting to their chair. So Maria Bianchi, manager of Verbagno Cusso Cossola, VCO, healthcare unit on clinical risk, Elio Tosati, secretary of Città Iniziative of the Lazio region. Dr. Bianchi is going to talk about the fourth age, aging well and healthy. This is going to be my problem in the next few years. And this is becoming more and more important in the next few years. And then we'll have Mr. Rosati talking about the healthcare communication. Good afternoon, ladies and gentlemen. The topic I was given is quite challenging because it talks about aging happily and healthily. I would say that if you age well, you age happily. Along my experience, I've noticed that if you are in pain, you're not happy and you don't feel positive. Therefore, I'd like to remind everybody that there's a law, 38/2010. It's the law about pain that has been discussed quite a lot, but I don't know why now it's been neglected. The problem of pain exists. It exists for all ages, and especially in the fourth age. We really hope to get there, but first, in order to get there, we have to be healthy. And in order to be healthy, we should follow certain rules. So we should exercise. We should keep intellectually active by following courses. And perhaps I could mention the experience I have at my local healthcare unit. Since we manage all companies' processes, I can tell you that I can gather the data that are provided by the geriatric unit and other structures that work with the geriatric unit for the management of elderly patients. And on the basis of this data, I can say that our local healthcare unit is committed in keeping elderly people active and happy, and that they can, for example, attend the university for the elderly or following courses, following dance courses, music courses, self-help. And we also have self-help groups that are responsible for the intellectual and emotional part of elderly people in order for them to be happy. We have also established structures and pathways in order to identify neurological problems. We always work in team. It's not only, it's never only one professional performing an activity. It is always a series of professionals, a group of professionals assessing each case. We monitor all cases, and we did so also during the pandemic throughout telemedicine. These are complexities that provide for answers, because it is important that the elderly patient, or also a young patient, must be aware of the fact that they are inside a social network. Because if you want to be a full individual, you should not be labeled as an elderly person. We should all be active, and you should be active in the society regardless of your age or regardless of your disease. So if you want to avoid osteoporosis, if you want to avoid fallings, very dangerous fallings, you should try to live happily in health. It is when it comes to when it comes to fallings, it is also something that hospitals should be more attentive about, because most falls of elderly people happens at the hospital. Until it is possible, the elderly can collaborate in the society. They may go for less challenging objectives, but they should be active and should be considered as contributors to the society. For example, I sing in a choir with people who are in the fourth stage of their life. They are in the fourth age. They never complain. Complaining is a key point, because complaining all the time is to the detriment of your well-being. So it is very important that you manage these elements, because they are strictly connected to certain diseases. So you should always look for what's beautiful, for what you like. And I think that culture can help us in it. The project our company provides are shared with public protection services. I'm talking about volunteering, and I'm talking also about people who work with people who are affected by Alzheimer, and there are some areas in which patients, Alzheimer's patients and volunteers work together and do music together. I had a video to show you how happy these people are and how connected they are when they do culturally and intellectually stimulating activities. I think that the mission of local healthcare unit is not only that of treating patients, but also that of looking into the happiness of patients.
So in the first half of the year, we have had 1,600 single services. Thank you very much. You've finished on time. You've been perfect. Yes, the issue of elderly people is huge. Clearly, when I speak about technology, I also speak about one thing. People say there is digital divide, the elderly cannot manage it, but actually some of them can manage it, others can be supported by other people. And then actually if they cannot use it, they won't use it. But I think it is worth giving it a try. And having all data related to an elderly person, especially when this person suffers from different pathologies, greatly helps the management of this elderly patient. So I think we should do something. Clearly, we need a system that can manage those data. So the organizational model matters. IT matters too, but that cannot do everything alone. That is trivial also. IT is just a tool. It is not an end. And it worked well also 15 years ago. The microphone is switched off. Thank you. There are some process and output get a result data too. So it is important to have a structure that performs those checks, because of course you have to assess the data. Data alone are nothing. And then corrections have to be implemented. Otherwise, nothing is useful. You need many data if you're able to interpret them, and then if you're able to implement actions that are effective. That is what we're trying to do. Yes, of course, data have to be produced well, first of all, because each one needs to know how they will be used. Yes, clearly, you cannot take them without purpose. We should remember that there are some data that are valid at a national level. Then we can discuss about the algorithms that are used. For example, for the elderly, there is the issue of some FEMA problems, for example, that are very important. And we extract data from SDO, that is the Hospital Information System. Those who add information need to know that they have to do it properly. But clearly, we need to assess those data in a critical manner. But anyway, data can support us. We know that if we do not take action for an elderly person, it is maybe because we do not have enough room or professionals. So the healthcare ministry is going to update our system. This is what I hope. Very well. Mr. Rosati will speak about communication instead, which, especially at COVID times, has been a particularly underestimated factor, to say it softly. Thank you very much for inviting me. I think that we should understand the whole environment. There is the medical and technological innovation, which is very significant. In 11 years during COVID time, we've had vaccines for a virus that has appeared all of a sudden all over the world. So on one hand, we have these elements of innovation that do not match the issue of the healthcare professionals. Somebody spoke about about the GPs. For example, in Lazio, GPs, thousands of GPs retired, and we have 4,000 GPs in the Lazio region, and 3,000 of them are senior. Clearly, we have to renew agreements related to retirement of those GPs, but I think that general medicine has changed greatly. But how can we reconcile all of that with the PNRR that provides for community houses and GPs on the territory? Dr. here is in Verbania. I remember that in the noughties, there had been a fight against the closure of a gynecology hospital. I know that the fight is not over. Italy is made up of Apennines for 40%. So we have 40%, we have people that live on the Apennines, and there are people in the Lazio region that do not have a GP at the moment. How can we reconcile all those things also in terms of communication? Because there is a communication gap, and not only a communication pollution that is incredible. On one hand, we have a technological and pharmaceutical technology that says tomorrow morning you will have the drug that will treat and cure the Alzheimer's syndrome, and some oncological pathologies will be treated at home. And I, as a citizen, and I might have had the problem, or maybe a family member has that problem and I am his caregiver. So, of course, I have a hope when I hear that such novelties are now available, because now it seems that technology will allow me to communicate with doctors much more. But today I cannot do that because I have to be in a long queue. I have to call the CUP. It is incredibly hard to manage to speak to the operator. Then there was a lady in Como that was called for a surgery after 11 years. This communication gap produces another divide between the healthcare world, that is the world that organizes the services, and the concrete world of citizens that try to have services for their health. And then one subject is lacking here, that the local bodies, when we talk about healthcare, and I look at the doctor here too, the ASL should not be alone. There should be the municipalities too, and the social policy bodies, because with the long life expectation, there is also the issue of chronic and rare multipathologies that have an impact on the state and region's finances. So how can we reconcile all of that? I think that we lack a global thinking, a community thinking. I think we should build a community welfare where prevention is the first step. Prevention starting from the schools where lifestyles are taught and where socio-healthcare teams can take action, because then when diseases start, it is already too late, because our country cannot afford to take action when the disease begins. The issue of crowded hospitals, we can see that the 60% of arrivals are not necessary. The arrivals at the hospital are not necessary, which means that there isn't a good organization in terms of GP and localized checkups. Clearly, then, there are attacks at the hospitals because there are people that wait for 24 hours before being checked by a doctor. But maybe those people go to the hospital because they cut their finger while they were cutting the garlic for the pasta. But this is a schizophrenic system. I think that we need a good doctor, probably, that cures all of us, because on one hand we have technological innovation, but for 25 years ago, the Ministry of Healthcare gave 2 billion lira to the ASL in Trento to do telemedicine in the valleys of Trentino region. And then decades passed. We almost reached the 30th year, and the technological innovation is unacceptable, is still unacceptable. Then there is the issue of defensive medicine, and we offer a service with citizens. They can this service allows them to assess their situation and assess the type of service that they can access to. But in 90% of cases, those patients should not actually. Based on those data, we can see that the healthcare operator, the healthcare professionals, the nurses and the doctors communicate very badly with the patients during their hospitalization. So these people get out of the hospital, think that they have been harmed, but the Lazio region allocates money for defensive medicine, and those money might be used for innovative drugs, treatments for rare diseases, and treatments related to social issues. So we expect a better reflection on that by everybody. we need to take action with with our hearts and with our minds in order to fill these gaps. Yes, it seems that now medicine sells everything, and we need to claim and we must be cured by everything, but that is not true. Prevention is also fundamental at any level. All lifestyles are key. There were projects such as gaining health and so on. Sometimes we speak about them, but those are things that need to be done. Clearly, it's good to have groups of elderly people that take action and do something. But we also need something more, yes. There are social services consortium, ASL, all these stakeholders should collaborate with each other. Not only spontaneously, but the ASL should organize such things. Clearly, GPs have an institutional mission and task. Clearly, if I cut my finger or I have a headache, I do not go to the hospital because that is not a proper behavior. So in that case, I have a white coat, and in that case, I can potentially wait for 2 days. So there should be a selection of cases locally. We cannot all go to the hospital in order to ask services that are not urgent. Because then those who really have clinical problems might not access the treatments needed. So we need to rethink the local medicine, which is what PNRR is providing for. I've been listening to the discussions on localized medicine for decades, and I hope it will become an effective service. The community houses are very interesting, but those things have to be done well. Clearly, we need the right content. We need the right networks of people, and not only technological networks and grids. The two things should go hand in hand. Sometimes people say, well, but everything is concentrated in one place. That is not necessary. There might be entry points that are more or less virtual, where information are provided. And so in that way, entry points might be placed anywhere in any municipality. The important thing is to give information, but of course you need a physical place that is a community house where you really find your solution. But there might be many satellites of that, and also the hub and spoke and the houses and so on. I have seen something very beautiful in the Cuneo valleys in the Alps. Once again, yes, but on the other side, where there are nurses centers that have been incredibly useful during the pandemic. Everybody knew the citizens and patients, the clients, and so they kept in contact, kept in touch with them. And in those cases, the pandemic has been less serious. So we not only need doctors, but we also need a network of nurses that are lacking. Just as we are lacking doctors, just as doctors are lacking, we are going towards ultra-specialization. And we've forgotten social aspects, the nurses and the GPs and pediatricians. That is the huge problem that we have, and we need to recreate that, but we do not have enough money. The healthcare funds actually will decrease compared to the general GDP with inflation and so on. They made a calculation, and it seems that the healthcare fund will decrease actually. So PNRR is a funding to make infrastructures, but the money that is not used for infrastructure should be used for ordinary services, for salaries, for example. But one part of it is freed. So if they spend money to renew the equipment and the buildings and to build buildings, for example, and you need also to spend money for maintenance and so on. But let's hope that some money will be used also for salaries. I am quite optimistic, but not much. Let's see what will happen in the next months, and then we will make decisions based on that. Are there other questions or remarks that you would like to make? I know it is quite late, but we are on time. We actually finished 45 minutes before the official end of this meeting. Thank you for staying here. We are 9 people here in person. We are quite a lot. Thank you. Have a good evening.